So today on the podcast Beyond Limits, we are joined by Dr. Chaitra S. Nirantra, a renowned immunologist, an accomplished gynecologist, and a reproductive immunologist practicing in Bangalore. With over a decade of experience in obstetrics and reproductive immunology, she is a well-recognized obstetrician whose expanse spans not only into reproductive immunology but also high-risk pregnancy, PCOS, and holistic women's health. Dr. Chaitra has been awarded the prestigious award, including the Sir P. Nagesam Award for Academic Excellence, the Karnataka State Award, and the Times of India Award for her excellence in healthcare. Beyond her clinical expertise, ma'am is extremely committed to giving holistic patient care and making sure that her patients receive the best. Today, we have an in-depth discussion about immunological disorders that can lead to high-risk pregnancies and the complications of it and how to deal with it. And we also go into great length of what are the disturbances that can cause multiple pregnancy losses, IVF failures. So we talk great lengths about the evolving landscape of immunology and the importance of immune health in reproduction. So, ma'am, I'm so happy to have you on this show because it's been such an incredible journey from seeing you in Ramaya as our senior postgraduate who always admired and adored you for everything that you have done, and to now having you on this podcast Beyond Limits. It's such a great pleasure. Like, you don't even know how much it meant because the first time I called you, you immediately said, come on, let's do this. It was so welcoming and warm. Thank you so much, ma'am.
You're welcome. I would definitely do this for you. I've seen the energy that you have.
Thank you. Ma'am, so today's podcast, we want to actually talk about something that I am very passionate about too, is women's health. Because I feel like in this space especially, there's not much been done for women, although we go through so much. I don't mean to say in a very feministic way, but there is menopause, there's menstruation, there is perimenopause, there's pregnancy, and then so many things related with the hormones that every month we go through. And now we're seeing that, there is a lot happening, but people are not able to understand where it is and how to approach these things. So I thought having you would be the best because you're a reproductive immunologist and you specialize in reproductive health. So to start off, ma'am, a lot of these days we're seeing that PCOS has become a huge problem. And so many people complain with it, but no solution. So what is it actually?
Over years, I have seen how drastically PCOS has increased.
Yeah.
Initially, we used to say 1 in every 3 girls is affected by PCOS. The number is much huge, is what I feel. The percentage by itself, multiple studies done in India say it is somewhere between as low as 3.5 to as high as 22.7%.
Damn.
So that's like a huge number.
Yeah.
This particular condition has multiple causes why it happens, but predominantly it is because of lifestyle.
Mm-hmm.
It is because of the restricted or a sedentary lifestyle, the diet that we are consuming, the stress that people go through. So it has a direct impact on your reproductive system.
Right.
It is very essential, when you go back and talk, and when we talk to our mothers, or when mothers or grandmothers accompany the child, especially with irregular cycles, they're like, what is this? In my time, nothing like this was there. In your time, I agree, nothing like this was there because your lifestyle was much different.
Yeah.
The food you consumed were way too nutritious.
Yeah.
So there was a lot of nutrition which went into the food that you people had. You did not have Swiggy and Zomato at your fingertips.
Right.
You just, order now and then.
Yeah.
So all these has a role to play.
Yeah.
But I personally feel the high number is mainly because of the lifestyle that one is following.
Yeah.
The horrid and the sedentary lifestyle. Obviously, you give a phone to a child at a very young age. It is very difficult for them to push them outdoor.
Yeah.
I would still want children to go out, play, get some vitamin D, get yourself, get drenched in rain, jump in the muddy pool, do all these things so you also pick up your immunity. Yeah. So these are the things that we have to I personally feel we need to put first. There are also other causes, the strong family history, family history with diabetes, or the mother having PCOS, associated thyroid disorders.
Right.
A high inflammation in the body is one of the key reasons why polycystic ovarian syndrome can develop. So there is also a genetical predisposition to that. But the most important cause would still be the lifestyle and the diet that we consume.
Ma'am, so like you said right now, lifestyle and diet, you mentioned stress, you mentioned also a lot to do with sedentary lifestyle. Do you think this doesn't start off at the ovaries, but it's to do with the HPO axis? And for people who don't know what the HPO axis is, the hypothalamo pituitary ovarian axis, which is in the brain. Can you explain something more about that?
Definitely. So basically what happens in very simple terms for people to understand, PCOS is where the female hormone declines and the male hormone tend to increase.
Right.
The major symptoms that women come are because of these. Mainly they'll have irregular cycles or long-term absence of cycle. Close to 4 to 5 months also there can be absence of cycle. They start putting on weight. There's pigmentations predominantly on the neck and underarm and the thighs. Hair loss, acne, we say male pattern balding, hirsutism, so growth of thick coarse hairs. So these are the symptoms you see, and these are mainly because of the male hormone which is increasing.
Right.
Now, along with that, we also talk about the insulin resistance that one starts developing. That is, its insulin resistance goes up, obesity goes up, PCOS goes up. So it goes hand in hand. So whenever there is insulin resistance, there is obesity, especially central obesity.
Yeah.
Like you said, hypothalamo pituitary ovarian axis. The axis has a very vital role to play because the trigger comes from up there. But the local inflammation, the polycyst, multiple small cysts in the ovary. So there are multiple small cysts. Without one being able to mature and develop into the oocyte for that particular month.
Right.
So until and unless one particular egg is chosen, well nourished, and that ruptures to form that month's oocyte. That doesn't happen because multiple follicles are selected in that pool. So that one capable oocyte is not developed. So ovulation doesn't happen. So inevitably she is not going to have her menses.
Right.
So this is a cycle you're talking about. It's like this: hypothalamus to the pituitary, pituitary to the ovary. But the ovary is failing to produce a oocyte.
Right.
So inevitably the entire axis is going to get disturbed. And over a period of time, it becomes resistant and more difficult to treat. So every time there is an irregularity in the cycle, the sooner you counteract it is much better. Otherwise, we're going to start pushing her into a higher level of testosterone in her body. Fasting insulin starts kind of going up. So these are the things that we need.
So ma'am, what do you think is the right way to approach PCOS, or the minute you see that you have some of these symptoms like you mentioned? One is pigmentation, hair growth in around the chin, around male pattern balding and central obesity. And I think the most clinical would be that your cycles are missing or prolonged.
True.
So what is the one thing or two things that you can say that one should do immediately or as soon as possible when they notice these changes?
Please visit a gyno.
Yeah.
It's as simple as that. Do not wait for your cycle. Many of them say, oh, she just got a cycle, first cycle. So they said it takes 2 years for the cycle to regularize. No. When your hypothalamo pituitary axis has to develop, it will develop. It has to. Every month it has to. So the further you're going to push, you're going to make it more difficult. And I keep telling my patients, I need to retune your body now.
Yeah.
So I need a little time. When you've come to me with an absence of 6 months, you need to give me some time to again bring all the hormones in the normal range.
Correct.
So the sooner, the better.
Right.
When you miss your cycle, like, in 10th, most of the girls, they come with this horrid irregular cycles. They come with such breakouts. They have so much of acne. Like, it's just way too much. And it becomes important for me to counsel the mother more than the child herself. I'm like, it is okay. The stress that you're in right now is pretty high. Let's try to counteract this together. It's not that you will sit down and wait for your cycles to come with that amount of stress up there. So make sure that you visit your gynecologist when you missed your cycle. She will definitely evaluate. All initial phases, you won't be able to see much. But progressively, when the follicles are much visualized in your scan, the hormone patterns in the blood, it takes a little time. But the sooner, the better. If you miss your cycle, meet your gyno to find out more. It could not necessarily be PCOS. It can be thyroid. It can be anemia.
Anything.
So,
and I think like what most mothers miss out is they think that it's teenage. So my child is having acne and it's normal. And this happens sadly in boys as well, and they end up with such bad scarring later on in life, which cannot really be corrected to a 95% level, which all of them want.
That's true.
Yeah.
It brings down their self-esteem so much. Especially I am seeing guys, boys with acne, their self-esteem kinds of drops. It's new hormone. Your body is getting exposed to that. There will be changes. But there's no harm in approaching the doctor, trying to find out what it is. And
Yeah.
basic medications. It
Yeah.
need not always be hormones.
Yeah.
It can be basic medication which can help them.
Right. And now, this starts off as early as the girl child is born, right? And it starts off, I think, as early as she is an embryo in her mother's womb, right? All of these changes. So, what most women don't understand is that they start blaming the child, that after she's born, we didn't take care of her, or she was very careless, or whatever. But they fail to understand that this is a problem which has started off genetically in your mother's womb, and then you've continued to ignore it, right? When we say this, they are like shocked that how can you blame us now, we did not know. But sadly, that is the truth.
The ground reality, yes, definitely, right. If the predisposition is genetics, like you said, way back when it was
Yeah.
just a oocyte in the mother's ovaries, definitely. But when it comes to PCOS, my personal feeling would still be the diet.
Right.
I would still say we have to do more.
Yeah.
I have 2 girls, and
Yeah.
trust me when I say I become one of the villain in the family when I say no, I'm not going to give milk to my daughters.
Yeah.
There's always an argument between my mother-in-law and me, and how can you say you're not giving milk to them? I'm like, the adulteration, the concept. I'm sure most of them are talking about it
Yeah.
now, and most of them are well educated about this.
Yes.
So it becomes essential. Now, if I'm not giving her milk, I need to find an alternative for her.
Correct.
I need to supplement calcium for her.
Yeah.
But lifestyle, that physical activity is a must. They need the physical activity. They need to cut down on the consumption of sugar.
Yes.
At the earliest.
Yeah.
The more we reduce, not just sugar, I would also say the packed food with high content of preservatives. They carry so much of preservatives, and these preservatives are one of the basis for any autoimmune disease.
Correct. 100%.
For me, for a metabolic condition like PCOS, I will still want to correct their lifestyle and physical activity.
Yeah.
Not to ignore, definitely have to
Yeah.
educate them. Like you said, if there is a family history, then the mother has to take charge.
Yeah.
She has to take charge way early. I have this amazing patient of mine. She knows her husband was diagnosed with diabetes, and he's slightly on the heavier side. And she's been so adamant with her daughter. This kid only came to me because she had a little bit of urinary tract infection. But when our conversation went on, and she's like, my mom doesn't give me sugar at all. So that kid has not had anything, and she doesn't have the craving for sugar at all. And I see how beautifully she has trained her daughter to not do what the normal consumption of bakery products or ice creams, any of these packet or packed food. In spite of her whole group of friends have been very much for ramen, and give me this, especially when the South Korean
boom happened. And
and everyone wants to have ramen now. So she was very adamant. She's like, my mama said no. She said, only because we have a very strong family history. I have seen my grandfather and father taking insulin. I don't want to do that. And the mother has trained her from the age of as young as 4 to 5. So the child is now 13, and she's so well trained. And every time I meet her, it's
and I think it's so beautiful, because I think children are what we teach them to be at the end of the day. So I think traditionally also, if most this ragi serai and all, everybody would put jaggery in it, saying it's very good. But now more and more studies are saying that the more we limit sugar, the later we give them, the better for the brain development.
True.
And I think moving forward to this now, since you said PCOS and everything, this definitely affects the way women want to conceive, right? So now a lot of women might be getting their periods every month, but then they would be trying and very hard to conceive. Suddenly they come to the gynecologist, and then they realize they're having anovulatory cycles.
True.
What is this anovulatory cycle?
So when we talk about an ovulation, there is absence of ovulation. So like I said, every month need not be 28 days. Need not be exactly 28, somewhere between 25 to 35 to 40 days. She has to ovulate. In the mid of her cycle, there is among the pool, one particular oocyte is chosen that develops, it ruptures, and that oocyte comes out. And that is that one cell which is going to become a pregnancy. Now, anovulation is where this oocyte development as well as release is going to be inhibited. This happens because of multiple reasons. Mainly, commonly because of polycystics. Or it can be because her reserve itself is very less. And I see very, very commonly these days girls as young as 25 to 35, this age group, 25, as early as 25, having very less ovarian reserve.
Hmm.
So if there is not a good number of oocytes there,
Right.
it's limited, uncontrolled thyroid, high levels of blood sugars, all these are contributory factors for an ovulatory cycle. So when there is no oocytes release, it's impossible that she can conceive in that month.
Right.
So these are the common causes that.
Ma'am, and moving towards conception itself, right? Now, since people are educated, you have the time to plan. You're not in a dark-sided, behind a curtain that, you have to conceive right now, right? But what are some of the things people should actually plan? I mean, preparatory phase. What should people actually be doing now in order to plan for a pregnancy?
Well, earlier, the fertility rate was pretty high.
Hmm.
And also, if you go back and look at the stats, the age at which a woman conceived her first child was much younger.
Yeah.
And today, women want to settle down in their career, which is definitely acceptable. But your career and your biological clock are always in a conflict with each
Right.
other. They are never going to support each other and stand by each
Yeah.
other. My personal opinion to girls would be, first and foremost, make sure that your reproductive health is maintained. There, you can be as healthy as possible. You need the basic workout. When your cycles are regular, you do not have any gut issues, good enough.
Yeah.
Initially, I used to force women to start their annual health checkup.
Yeah.
Very essential.
Yeah.
Indian women, vitamin D, vitamin B12 deficiency, unexplained hypothyroidism. Now,
Yeah.
hypothyroidism also is on sky high right
Yeah.
now. So I would suggest get your annual health checkup.
Yeah.
Also try to include AMH, anti-Mullerian hormone.
Yeah.
So I know what is the oocyte in
Oocyte.
your system. So when I do your routine checkup and everything seems to be good, your system is good, your body is good, the lifestyle that you're following is pretty good. But if there are variations and we diagnose it much earlier, you can correct it over the
Yeah.
process.
Yeah.
And I still don't have to jump into doing any active intervention for that. But what say when I do it and you're a very young girl, you're only 25 and your AMH is way too low.
Right.
If you want a baby who's going to carry your genetics, I may suggest you to do something called egg freezing.
Right.
I'll take out the eggs, freeze it, concentrate on your career, and when you're ready, we will go ahead and fertilize that oocyte which we have preserved over years and transfer it into you. So for me, very essentially, reproductive health in basic test, just a simple ultrasound, your vitamin D, vitamin B12, hemoglobin, blood sugars, thyroid. And now I would personally really want to include AMH in their panel. So
I mean, also want to include one more thing, which is very, very surprisingly low in today's women is iron. I find it absurd that I don't know if it's our genetics that we don't absorb iron well, or I don't know whether it is traditionally not included in our diet, or people just have stopped eating iron-rich foods. But normally, when we see most of the antenatal cases at the hospital, iron levels are at the lowest. HB is at 8.
yes.
So by the time they reach pregnancy, like 9th month, we have to end up transfusing iron or 1 pint of blood. This has been like a regular thing that is happening now. It was not the case earlier, but why?
The population which is really affected with anemia, I would say, is the lower middle and the lower class population. Now, definitely their diet is limited.
Right.
And when women come and it's very true, very true. When I'm in a PHC and I'm looking at any patients, their HB, if it's 10, I would want to celebrate that.
Yeah.
But 8 is the commonest number that I see on their charts. Their hemoglobin is always way too low. It becomes essential for us to first see, is it because she's losing somewhere? Is she bleeding internally? Deworming is not done in n number of women, especially in the lower middle class and the lower group of socioeconomic status women. Along with that, their dietary deficiency. When, first of all, in vegetarian food, we have limited resources.
Right.
And in non-veg, because of the adulteration, there is limited amount of actively available iron for absorption into the system. And one other thing that I recently observed, and we also had a huge discussion, amazing discussion in our recent national conference, was about how inflammation in the gut is preventing absorption of these very vital elements like iron, zinc, magnesium, because of the gut inflammation.
Yeah.
So that is again one of the contributory factors.
Right.
So yes, anemia like I said, HB has to be included in your panel, but anemia has to be addressed.
Right.
If maybe it's as simple as deworming, maybe that would
Yeah.
help her. If she is deficient, then substitute. We give her a very clean, neat diet, as simple as good. Jaggery. When I was in Punjab recently, I was lovely. I got an opportunity to be with one of this amazing gynecologists who used to work in this very nice remote village. And I just sat with her for like half a day, and she insisted on the women, good nahi hai kya, aap kha lo. So she used to tell them, and that is something which is available, purely available there, and because of the high availability of iron, that should.
Right.
But gut health, again,
Yeah.
I personally feel this definitely has a role to play these days.
Ma'am, and moving forward, you said egg freezing. Now, there is a lot of, myths behind egg freezing. One is that the number of eggs that you freeze today might not be viable when you thaw them tomorrow.
Yes.
So, a lot of women now think that I have frozen my eggs, I am good to go. But there is a surprise element when they thaw those eggs 10 years down the line. How much viable is this? Because if somebody is thinking this is my final 100% option, because IVF clinics are selling this right, left, center.
I'm freezing a single cell.
Yeah.
So definitely, what actually makes a difference is what was the quality of the egg when I retrieved it.
Right.
So you had a very good quality of the egg which I retrieved and I froze it. Then definitely when I thaw it, I will have a good oocyte. But it again depends on when you have. Right. And how much you have and what was the quality when I retrieved it. Right. So there's no exact percentage and no one can say 100% I have frozen 10 oocytes for you, I'm going to give you all 10. 5 years down the lane, not happening.
So I think whoever is freezing should be very well aware of this, that ask their doctors that what is my quality of the egg, not just be happy that we have gotten eggs.
True, very true. You need to sit and discuss with your gynecologist, your IVF specialist, get a clear opinion on how exactly it is, what is the amount, what are the oocytes which you think will be available 5 years down the lane. I'm sure they'll be able to give you an answer.
Yeah. And now since we said IVF and so much, lot of them now, first of all, tier 3 cities, tier 2 cities have IVF centers. This has become a common thing. Like literally, my grandparents were telling one of my cousins who have not conceived that why don't you all try IVF? Like it has become a common thing. Why is that so? And another thing is a lot of people are trying IVF for 3 years, 4 years, multiple failed cycles. What is happening and why?
Yes, there are a lot of IVF units right now. 15% of Indian population are thought to be, studies support the fact that they are infertile and may more so in a urban population, in a population which has all the requirements available, I would say. Now, as far as why the need of IVF, because of the causism. Now, there are some set of causes which will definitely require IVF. Like example, we'll talk about, we all know there's one uterus, there are 2 tubes and 2 ovaries. The egg is relieved from the oocyte, comes to the fallopian tube, pregnancy happens in the fallopian tube, comes and gets attached in the uterus and grows. If there is bilateral tubal blockage, there is no way that the egg is going to migrate and come, nor the sperm has the pathway to go to the oocyte. Yeah. So in that case, definitely IVF is an option for us. Now, why the tube gets blocked, chronic infection, endometriosis, TB of the pelvis, there are multiple causes. So this is one of the commonest one I'm saying. When there is bilateral tubal blockage, definitely IVF is an option for the woman. In a man, when there is azoospermia, obstructive, non-obstructive. Sometimes temporary, when it is because of a viral infection or endocrinological, which is treatable. So when there is azoospermia, also they are suggested male factors. So we suggest them for an IVF. IVF is where the oocyte and the sperm is mixed, formed an embryo, and at the right time, studying the endometrium, that is the lining or the bed of the uterus, the oocyte is, the embryo has been transferred. Yeah. Well, now why is it increasing? Is because there are tubal factors are also increasing. Lot of sexually transmitted infection leading to tubal blockage. Like I mentioned, very fast the oocytes are declining. Right. So it could be ovarian failures or low ovarian reserve. male factors. Also, I must mention that I am seeing a lot of erectile dysfunctions over the past few years. And over the past 1.5 years, it's been quite high. And one of the main reasons, treated with multiple endocrinological support, psychological counseling, they also called for, many of them, most of them rather, opt for IVF rather than an extensive treatment.
Right.
So when there are, like I mentioned, grade 4 endometriosis, like this is where there's a high inflammation, the quality of the oocyte is dropped, the tubes don't have the capacity to push the oocytes. So these are the women who will require IVF.
Right.
Now, why it is increasing? Infections are high, the ovarian reserve is high, male factors are also peaking high. Also, like we said, this polycystic ovarian syndrome also comes into this category.
Right.
They become very resistant ovaries. They do not respond to even a very high dose of medications which is administered. They also call for an IVF cycle. So I see a lot of women going into IVF. Now, the second part, when you asked about years together and failures, well, in simple terms, when patients come to me, I tell them, see, it's like a plant. You need good seed, you need good soil.
Right.
Maybe there are some problems and IVF is an option. But immunologically, like what I do as a reproductive immunologist, I will want to study the endometrial bed for her.
Right.
I will want to see the fertility of the endometrium. So if there's some cellular imbalance, maybe she has an amazing thickness, good blood flow to the endometrium lining, but what if the composition, the cellular composition is abnormal?
Right.
So that is one thing that I will definitely want to study in these women.
Yeah.
Isolated elevation of certain antibodies in the system can be one of the reasons why the implantation is prevented.
Right.
So it's a beautiful process. Okay, it's not as simple as one egg come, one sperm, one embryo, and no, there's too much. The hormonal factor, the anatomical factor, the endocrinological factor. It has to come together.
Correct.
So it has to happen for you to have a successful implantation.
Correct.
So when repeated IVF failures, I do feel immunological evaluation will definitely help them.
Right. Ma'am, and can we break down for the common people what is immunological evaluation? What are these antibodies and what is the endometrium? So, because most people understand uterus is there, eggs are there, sperms are there, but they will not understand when we say there is an endometrium, which is one other organ. Because I think most people just think this is it. If these three are functioning, then we are good to go.
True.
So can you tell us what is the endometrium like?
I'm just so happy that you kind of asked me this. Now, when I say basic immunological test, let me take an example of a case and tell you more. So I have this 39-year-old who came to us 3 years back with 3 cycles of IVF failure. 2 was done with her own eggs and husband's sperm, and 1 transfer was done with a donor egg and a husband's sperm.
Right.
So here what happened was, when she came with a detailed history, we found out the age at which she started her IVF cycle was when she was 37.
Okay.
Her egg quality, or the AMH at that point of time, was 1.3, which is still okay. So, and she was getting good grade embryos also. But now why repeated failures? There was not one time she had got a positive beta HCG.
Right.
So then we try to evaluate her more. Her background check told me that she had a very unhealthy eating habit, I would say. So that kind of tells us that the gut health is kind of disturbed. But basic immunological evaluation is done to see if there are certain antibodies in your own system which is attacking your own system.
Right.
So that's called an autoimmune disease like ANA.
Yeah.
Many of them must have heard about arthritis. It's one of the common rheumatological and immunological disorder, wherein your body starts attacking your own joints and creates an inflammation in the joints. So here what happens, there are multiple antibodies, but specifically some antibodies are something which is going to create such an irritable environment in the uterus that prevents the beautiful embryo to get implanted into the, when I say endometrium, it is the bed of the uterus.
Correct.
Where the baby has to come and get attached. So whenever there is an abnormality when it comes to these antibodies, your body is not supposed to attack your own system.
Right.
When it starts attacking your own system, the body's inflammation increases.
Right.
Example, thyroid. I have this is thyroid gland is a factory. The cells in it are the employees. It is going to produce a thyroid hormone and put it in blood. When my immune system, by mistake, starts attacking it, the output, which is a thyroid, is going to reduce. Also, there is an inflammation which is creating. So this is the autoimmune basis for it. The first thing I did for her was evaluated her for any autoantibodies. She was a pre-existing hypothyroid. She started off with 25 mcg, but progressively, when she came to me, she was taking 125 mcg. So progressively, the thyroid levels were, thyroid medications were increased. When we did that, we found out her antibodies were very high. Both her anti-TPO and anti-TG were pretty high. So she was diagnosed clearly with Hashimoto's thyroiditis. Started her on basic immunomodulator. Over 6 months, it slowly came down. Her TSH would also kind of stopped fluctuating. The medication she was taking of 125 was brought down to 75. She started having good ovulation. And at the end of 6 months, she conceived. She conceived luckily naturally. And she delivered a baby boy at 9 months. Apart from the later month, which gave me a little trouble because of the growth restriction, that was after 37 weeks, I did not face problems with her. Her thyroid was quite stable. The same thing, similar history, is something where I want to evaluate the bed, like I mentioned. I look at some cells called the natural killer cells. They play a very vital role for the development of the blood vessels between the mother and the baby. In very simple terms, for people to understand, they play an important role in developing the connection between you and the baby.
Child.
So these NK cells, when they are, it is not good for them to either be high or low. So it has to be in a very limited proportion in your system. Those cells are evaluated. And if they are abnormal, they are nothing but cells which are derived, or I would say promoted cells from the peripheral blood in your... so these cells also have to be evaluated. And isolated NK cell abnormality in a study that we had done showed that the rate of success is pretty high with just basic immunomodulators. I should not have any other cause like tubal factors or low ovarian reserve. Only NK cell abnormalities, treat them with basic immunomodulators. Over a period of time, the rate of natural conception and pregnancy outcome could be good. And the last one, and one of the commonest one, it will not present as, commonly won't present as implantation failure or infertility. It will present as recurrent abortions. That is
recurrent. This is like a big question mark on everybody's face. They'll be like, we conceived, but in the 2nd month, we did not get a heartbeat. Conceived, 3rd month, missed abortion. Or conceived and spontaneous abortions. This even goes on to 2nd trimester, and then they have a spontaneous abortion, which is very painful. So what could be the reason for these spontaneous abortions, ma'am? Because one, we said, rheumatologically, it could be because of your rheumatoid arthritis or any other autoimmune. What could be the other diseases that people actually don't know that they should reach out and check for these?
True. Well, like you said, the question mark, definitely. If you would have asked me 3 years back as an obstetrician also, even I think immunology in obstetrics needs a little more importance in today's world. It could be as less as 10 days, as long as 3 months. The pain the mother endures is going to be the same. She sees the 2 lines on the pregnancy kit and her entire world is changed. It is just her, the baby, the baby, the baby, the baby, nothing else. Especially for a woman who's undergone abortion, it can be 1, 2, or 3. She is going to go through a lot of emotional, it's a roller coaster ride for her. Now, these causes, like you mentioned, they'll get pregnant. I see the beta HCG going up. I do a scan. I get beautiful baby. Baby's heartbeat is there at 7 weeks. The next time she comes, we lose a baby. Commonly, when I lose a baby in the first 3 months of pregnancy, it could either be genetical or it can be a condition where there is a thrombus or a clot formation. So when the vessel between the baby and the mother, there is inflammation and there is blockage of this because of a clot. It could be a hereditary thrombophilia or an acquired thrombophilia. So In the first 3 months, I would definitely want to work her up for her basic hormones,
Hmm.
to see for her progesterone, her sugar levels, her thyroid. But I will definitely also want to evaluate her genetically, both
Yeah.
the husband and the wife. Also want to look into her APLA panel.
Hmm.
Our
Before you
strict
go, can you expand APLA panel?
so it is anti-phospholipid antibody syndrome.
Yeah.
It is an acquired thrombophilia.
Yeah.
It has various components below it, but the common ones which is evaluated are lupus,
Yeah.
beta-2 glycoprotein IgG and IgM, and anti-cardiolipin antibody IgG and IgM.
Right.
Now, whenever we talk about antibodies, when we say IgG, it is a past,
Hmm.
and IgM is present.
Right.
But antibodies, these antibodies, when present in the system, can form an inflammation and clot in the vessels,
Right.
which obstruct it, and the baby needs the blood to grow. So these women usually present with early miscarriages. They see
Hmm.
the heartbeat, the world is
Right.
changing for them, and unfortunately, we lose it. But I'll tell you one thing. APLA is that one condition, if you treat it properly, we have a successful outcome.
Right.
And I really like treating APLA patients because I know I can give them a successful pregnancy
Right.
if treated appropriately. What is more challenging is the ANA and SLE.
Yeah.
But
So, ma'am,
APLA is...
to put together, so APLA is basically a disorder where once the blood vessel has been formed, somehow because of the autoimmune response, there is a clot formed. Hence, essential nutrients not transferred to the baby, and hence you have a abortion or a missed pregnancy or missed abortion, whatever it is. So the main reason is we basically check out for all of the antibodies, and I think once any woman has gone through such kind of a thing, is to initially reach out to a reproductive immunologist and say that these are the complaints that I have. So because what happens is most of the times they will come and they'll hide the history. How many abortions you have had, they will look that side, this side. And it's very sad because they are embarrassed thinking that it is their own problem. Something is wrong with them, that they are not able to carry forward a pregnancy. But I feel like if they can just tell us the history that this has happened, then the diagnosis is really quick in terms of what can be best done for them.
Very true. Very, very true. I would love it for my patients to be very clear with me.
Yeah.
Please tell me your history. Your history will almost narrow down the diagnosis. It's not that I need a set of hundreds of blood tests. Your
Yeah.
history will give me a rough idea of what it could be.
Right.
I'm definitely going to make sure that that is the diagnosis by working you up with few
Yeah.
laboratory tests. But definitely a history is way too important.
Yeah.
These particular patients, and we are talking about long-term infertility or recurrent pregnancy loss, you cannot generalize the treatment for them.
Yeah.
It has to be customized, curated only for them.
Hmm.
Every single patient is different.
Right.
At what time am I going to increase steroids for you? At what time am I going to reduce it? When is the place where I'm going to give you ecosprin, heparin? It is very much customized only for you. Only
Right.
because your neighbor had 3 IVF failures and then she took something and she got pregnant, it is not essential that it is going to
Yeah.
happen to you.
Ma'am, and another thing is most people will be like you said, my neighbor went to this clinic, 3 failed, 4th she went to the second clinic, so I'm going to go to the second clinic. But what most people fail to address is that what are my things? How is my body responding? Do I have any pre-existing condition? Because they're all eager to just get pregnant.
Agreed.
So
Agreed.
how do you check for APLA, SLE, lupus, or autoimmune disorders, and how should one actually assess and progress on this journey?
Well, I'm extremely happy to tell you that the Bangalore Society of Obstetrics, most of the IVF centers are extremely in a good condition or good relationship with the immunology centers, and we work hand in hand. So most of them, I feel I've made more number of IVF friends after becoming an immunologist, and I must say they're doing an amazing job.
Yeah.
So it's very clear when it comes to this. They work them up, they find that this is the abnormality. So very thoroughly, they will evaluate them, and if they feel it is essential, it is referred to
Right.
an immunologist. So when an immunologist has been referred, we work up for the basic test. Like I told you, I will not do all the tests for everyone. It depends on her history. If she had her abortion in her first trimester, like I told you, I will do basic evaluation. Most of them would have already done their hormonal panel, anatomical, that is
Yeah.
the uterus, the pattern. All those is worked up.
Yeah.
I will dig more into the immunological panel.
Right.
So when I dig into the immunological panel, I just find that this is the abnormality. So we make sure that we have a conversation with the IVF unit, inform them that this is what is happening, and we work hand in hand.
Right.
And this is really working well. Like I told you, the success is pretty high. I tell my patients also, if I find an immunological disturbance in your system, I am useful to you.
Yeah.
And if I find APLA in you, I know I'm going to give you a good outcome.
Yeah.
So I need to know the diagnosis.
Right.
Immunology steps in when you have to little more, you dig into a little more of it. Earlier they used to say, unknown causes of infertility was a little high, but since immunology is coming in right now, so most of them are coming to the immunological bed.
Right.
So basic immune modulation helps in a woman's system to recover so well.
Right.
And it just facilitates the easy implantation of the embryo further she's going to have from the IVF unit.
Ma'am, so now moving forward, SLE is a big question mark. So nobody touches SLE, saying if you have SLE, they immediately write them off. You cannot have kids. Please adopt, or you have to get a donor egg, whatever it is. What is it? Why is there such a big question mark on it?
SLE, if it's well controlled, please, no. You can have your own eggs. You can have a natural pregnancy. You can bear the child. But let me tell you, I've been trained by Dr. Chandrasekhar. And I've heard Sir say this n number of times. SLE is like a cobra. When it is sleeping, it's good. But it is unpredictable. When it's going to trigger its own, you cannot say. And SLE is just like that. Now, initially, when Sir used to say this, I used to be like, okay, but after facing pregnancies with SLE, I understand the ground reality. But again, the nicer part, I'll tell you, out of the number of cases of SLE that I have done, women with well-controlled SLE have a good pregnancy and good pregnancy outcome also. It is not essential for them to always go for a donor egg or go for an IVF cycle. No, but an uncontrolled SLE, this is where the challenge arises. First and foremost, the medications that they are taking. SLE is a multi-systemic involvement. It is one condition which is very unpredictable. So SLE, when it is uncontrolled, first of all, the immunologists are very clear, please do not conceive. Mainly because of the medications that you're on. They are definitely not suitable for the pregnancy. They're going to harm the baby. So most of them, when they are in a flare of SLE and they are taking high medications, when they conceive, it is advised for termination because of the lethal effect that the medication has on the baby. But after I control the SLE, and if her immune system is catching up and it is well controlled, yes, but you have to be thoroughly and continuously monitored. Plain SLE and associated with APLA also come, antiphospholipid syndrome. So these are the women which needs a little more. Usually we do what, 3rd month, 5th month, 7 to 8 months scan. But these women will need more. I may want to see you every 2 weeks till you establish a good heartbeat. I'll be extra cautionate with you looking at the blood parameters. I may do a more number of tests. But the catch here is these antibodies, some of these antibodies like the Rho antibodies, they can cross from the mother to the baby. And this is the common questions they ask. That is the reason they ask, can I have pregnancy? Now, these antibodies in the mother has a capability to transfer through the placenta to the baby. And here what it does, it will go and affect the baby's growing heart. And it causes a blockage of the conduction in the heart. So the baby will have problems associated with that. But having said that, a woman who is under control and well monitored should not be facing issues. Even though she is going to develop some effects. From as early as 16 weeks, I like to start monitoring the baby's heart. So that is where I tell every 15 days, I have to see the patient. I have to look at the baby's heart and the PR into it. So if the baby is doing good, I'm happy. But if there are some disturbances and I'm seeing some abnormality in the PR interval, that's the baby's heart, I would want to initiate some extra medications. So I may step up the steroids that I'm giving her. Also beautiful medications like IVIG I can use in these patients, which has a good outcome again. So these are the things that I will want to do. So yes, SLE is a high risk pregnancy. Has to be managed in a tertiary care unit. My sincere suggestion is please conceive when you're in the remission phase. Talk to your immunologist, find out if the medication is suitable for pregnancy. They will bring it out in the base immunomodulators. Look at the blood parameters. conceive.
Right.
Close monitoring of the baby through and through the course of pregnancy should be a good thing.
Yeah. Ma'am, and what are the other high risk pregnancies in fact, I want to put it as that you would term as high risk?
Immunologically, if you ask me, definitely what tops the list for me is SLA. APLA also does, especially when there are triple antibodies, when all the three antibodies are positive, also can. A woman who's having pre-existing cardiac problem, definitely a high-risk pregnancy. She's having associated conditions like
Right.
high blood pressure, she's having chronic kidney disease, liver failure. I had one recent patient with factor V deficiency.
That's very uncommon. But
Very uncommon, and I think I must have skipped the entire sleep cycle for a good 1 week till she was there. I would not just say me, it was my entire team, starting from my anesthetist to the ICU team to the nurses on duty. Everyone were on toes from the time she entered into the hospital till the time she exited.
yeah, to just clarify, factor V is one of those coagulation factors which is necessary for your blood to clot.
True.
So that means if this patient even had a tiny cut, that would be an emergency where we would have to rush her because no way to stop her bleeding.
True.
And no way to control the bleeding, which means baby would have been lost and mother.
Exactly. I would have, we were very concerned for her. I must say my ICU team was amazingly backed up. My hematologist was on spot. So we had good blood available, ready. I had my interventional radiologist in case need arises. So the case went good, I must say.
Yeah.
So any factor deficiency, clotting factor abnormalities also come under the category of high risk.
Right.
Also, if the person has had previous history of clots, if she's had any deep vein thrombosis, protein C, protein S deficiency, they also come under the category of a high-risk pregnancy. Now, apart from immunology, if I have to talk about, like I mentioned about the cardiac abnormalities in the mother, placenta previa.
Right.
A nightmare for obstetricians. So this is one condition where the placenta is what is supposed to enter is the baby's head, but the placenta decides to obstruct it.
Yeah.
So when there is cervical dilation and the placenta is getting separated, torrential bleed.
Yeah.
So the mother's life is at stake there. Preeclampsia, which is something which I feel is right now addressed pretty well.
Yeah, I think we have very good guidelines. Once you say preeclampsia, prenatally and antenatally addressed very well.
Very well.
Preeclampsia, to just break it down, is hypertension in pregnancy.
True.
Right.
So preeclampsia, I feel it's very nicely managed nowadays, and especially in my state, I must say, they are catching up.
Gestational diabetes and preeclampsia, I think, are over and abovely well managed.
Right now, I would say, okay, I would not be very sad. I don't want to lay back and say satisfied anymore, but I would say I'm happy to see that there is reduction in the mortality associated with it. People know when they have to refer her.
Yeah.
People know when we have to, especially from peripheries, when they have to refer. That is also happening pretty good.
Right.
Now. So the system is doing something right, and I must give the credit to the Bangalore Society. Extensively, they are educating women.
Right.
So again, preeclampsia and eclampsia, with whenever there is high BP and there is fits in the mother, there is a possibility of internal bleeding. So abruption, and that leading to a lot of other complications, definitely a high-risk pregnancy. So
what percentage of these women who are generally conceiving in and around Karnataka, if I were to take the numbers, are currently high risk?
A lot. I would say the numbers increased.
Yeah.
I'm not going to say because of preeclampsia and eclampsia,
but autoimmune basically.
Pretty high.
Because another thing which I was also seeing is autoimmune thyroid is on the rise. I don't remember in my entire MBBS checking anti-TG, anti-TPO. Now it is a must.
In any infertility workup, you will see the TPO,
and
TG.
also any woman who comes with thyroid, we do check anti-TG and anti-TPO and they are high.
I'm so happy that people are, deciding to do it.
Yeah.
Definitely worth doing.
Yeah. And ma'am, another thing is, do you have any personal cases that you have worked on? Because, IVF, they come with such a huge folder.
True.
What has your experience been? Can you share some of your personal experience?
Well, something which is very close to my heart, I'll tell you. This one case has been, I feel, when I started working as a reproductive immunologist, I started investing myself emotionally also there. The case, like you said, the case is this big. you inevitably, when you're talking to them, sometimes my staff comes and tells me, Madam, it's been more than half an hour. I'm like, I'm still haven't finished taking the case history also. And you need to give them that amount of time. They deserve that amount of time.
Right.
If they're coming to me after that huge medical history, they deserve the time in the first place.
Yeah.
So multiple IVF failures, women are drained out. Like you said, not happening, just go get IVF done. But one IVF failure will break them.
Yeah.
It looks like a dead end.
Yeah.
So, but trust me, IVF also has expanded so much right now. We have so much coming into the treatment right now. I'm sure if a case is managed properly, most of the cases are cracked. Now, this particular case, she came to me with 3 second trimester losses. All of them were lost after the baby was minimum 20 to 24 weeks, that is between 5 to 6. So when she came to me and she's like, she was referred by one of the other gynecologists, and we went through the history, did her basic immune workup, and we found very minute antibodies to be positive. We started her on basic immunomodulators, and then she conceived. But the very first time she came to me after the 2 pink lines, she said, I don't have the energy. I don't think I can put another baby to the grave. She comes from a community where even a 5 to 6 month old had to be buried.
Right.
And they have to do certain rituals. She's like, I can't dig another grave. I can't do this. So she became like a part of my prayers, I would say. But that 9 months of journey for her was as difficult as it was for her, it was for me.
Right.
So that is when I realized at one point I really felt I was getting too tangled with the cases that I was working on. But she was one of my first few ones. So then we started working on her, gave her immunomodulators, things went good. Why we lost the children were in that second trimester, 5 to 6. All the baby, particularly there was hydrops. The baby started swelling inside the uterus. We had ruled out all causes, starting from parvovirus to subgrouping of blood typing also I had done. So, but basic immune autoantibodies. When she was 36 weeks, till 36 weeks, the baby was pretty good. Slowly polyhydramnios, that is water around the baby started increasing. That is when I decided I'm going to take out the baby. So we delivered the baby. Baby girl did fantastically well. She's doing good. She's, I think, now 3 years plus. She's been someone who's very close to me because this was one of the first few cases that I had handled. Following this is where I realized multiple cases requires a lot of attention from us.
Right.
As an obstetrician, I cannot hustle. I can't hush up and finish my cases. It just doesn't work.
Right.
I need to invest that amount of time to understand what was her background. What are the investigations? What were her hormones? What were her scans? Is there more that needs to be worked upon?
Yeah.
So then is when I decided I need to start. Every case is different for me.
Yeah.
It cannot be. I can't say, many of them come and say, you delivered her, why can't you do for me? It's not as simple as that.
Yeah.
No, sit down, let's talk now.
Yeah. So does each case somewhere down the line change your personality and impact you in ways that you think have really changed you as a person?
Definitely. Like I said, initially when I started doing this, I was emotionally dragged into this. But I must thank and mention my husband. Being a medico, I think it really helped a lot. I would come down. I would carry back the cases from the hospital. It's always on my mind. I still come back home with the cases. I'm still overthinking. I am still reading about this. Every case is different. So you have to sit and read. So there were days that I used to sit late nights to read more and more to find out if there's something else that I can do, something different that I can intervene and try to save the baby. So that is where the family steps in. As an obstetrician, your family has to be something who's going to be supportive. And touch wood, my husband been extremely constant with that. So he was good. He was like, okay, if this is what you want and this is how much you want to. But I also feel over years, I have grown as a person. I have grown to understand that my patients are important to me. I cannot let my emotions come in the way.
Right.
I really have. I'll be able to do better when I don't let my emotions come in the way. That is as simple as it is. Initially, it used to be more of, my voice used to change up and down. And now I myself see how I'm in OPDs and I'm talking to patients. If I am going to let myself low, it is going to be difficult for her. And she needs me at this point of time.
Yeah.
So definitely I see the way I have grown in my feel as an immunologist, my patience is decreased because my OPDs does not wrap up early.
Yeah.
It is way too long. My staffs, my family has been constantly supporting me.
Right.
And more than that, I feel the research.
Right.
The new intervention, the new therapies that we are introducing is what is making a lot of changes.
Right. And can you also tell us a little bit about LIT? And before we go, expand on LIT, because most people will not understand the minute we say LIT.
So leukocyte immunization therapy. I'm
Right.
so glad you brought up this. It's like the new thing right now. And I see a lot of, recently one of my patients came to me and she's like, you see this reel, okay? You see this reel. I'm like, what is it about? It says something called LIT. You give me LIT, I'll conceive. Okay, let's talk it. Well, this is where LIT is a therapy where, in simple terms, I would say sensitizing your body to the husband's genetical composition.
Right.
In more simple terms, to make your immune system kind of friendly with the genetical composition.
So it's the making your immune system friendly, not but physical friendliness with your husband.
by that. So this is what this therapy does. So basically how we go ahead is we need to do a HLA typing for them. It is the surface antigen has to be analyzed for both the husband and the wife. Once we analyze the surface antigen for both of them, we see what is the similarities.
Right.
LIT will only benefit you if there is more than 50% of a match.
Right.
So you have to do your HLA test. Only if the reports are conclusive that you will benefit from LIT, that is when LIT will be given.
Right.
It's a very simple OPD procedure where we take the husband's blood, we work on it a little bit, extract certain required cell and inject it into the woman. We do, usually what we do is 2 doses before we send them back for their fertility to carry on, like an IVF, IUI. So we give them 2 doses, 15 days apart, and if need arises, 1 even after the pregnancy is positive.
Right.
So how, only if it's required.
Only if it's required. So who is the candidate for LIT, first of all?
That depends on their HLA. Okay. I want to do your husband's and your HLA, match them, and only then will I be able to tell you if you will benefit from it or not.
Right. And this is for people who have many miscarriages and
long-standing infertility.
Got it. And with high risk also, since you said APLA, all of these immunological, there is a high use of steroid.
Yes.
And with steroid comes other complications. Number one being you lose your bones.
Yes.
How do you deal with this? Because, and you, like you were mentioning earlier, a lot of cases wherein, people have come with 20 grams of steroids, 20 milligrams of steroids, that they are using. And what is it that you see when you see such kind of cases?
The first thing, for an immune disorder, yes, steroid may be essential. The woman's inflammation, her body weight, the requirement of the steroid is what is important. I would start with the base minimal dose. I will start with the base minimal dose. If need arises, I increase. Most of my patients, they know that when I start, I'm counseling them by saying, I may start you on steroid. Wait for the complete implantation to happen and maybe I will slowly taper and stop it. Steroid, first thing, start with the base dose. See the body response. Always before initiation of steroid, you have to make sure that her bone mineral density is evaluated. We know her vitamin D levels. She has to be supplemented with vitamin D and calcium. Like you said, one of the commonest complications. And in pregnancy, when I use it, the other thing is sugars. Shoots up. Especially if she's a type 2 diabetes, it's very difficult to convince her to take steroids.
Right.
But once I put steroids, basic dose for her body weight, only if need arises, I may increase it a little bit. But definitely be monitoring her bone health and sugars very closely. There are certain complications that I have seen where there is very high dosage of steroid used. And some of them have gone into compression fraction of the spine in pregnancy, during the course of pregnancy. They take a very long time to recover. So when you are giving them that amount of steroid, please also give them the support which is required to counteract the side effects of steroid.
Right. Ma'am, and is there like an advice that you want to give out to women who are trying to get pregnant? I wouldn't say women, to couples who are trying to get pregnant.
I love the fact that you mentioned it. Well, recurrent pregnancy loss need not always have to be the woman. It's very nice how Indian population are now accepting the fact that infertility can also be because of a man.
Right.
A high DFI, DNA fragmentation index of the sperm, can also be one of the causes of recurrent abortions. So the first thing I would like to tell my couples would be evaluate both.
Hmm.
It is impossible for me to evaluate only the woman and treat her continuously for years together without evaluating a man.
Right.
I will want to evaluate the couple as a whole.
Yeah.
The second thing would be act early.
Hmm.
I respect the fact that career is important, but also make sure there are many celebrities who go in
Yeah.
for egg freezing and some of them even for embryo freezing.
Yeah.
Make sure that you are well aware of your options. Your health has to be on point. Even if you're going to freeze your embryos, I'm going to be transferring into your system tomorrow.
Yeah.
You have to maintain your health. So for the couples, especially the ones who are fighting with infertility, evaluate both. Make sure that the diagnosis is drawn. Once we know the diagnosis, it's easy to work on you.
Right.
So that is what I require. I need a proper working diagnosis. I need the diagnosis for me to tell you what is your treatment module,
Right.
how we are going to proceed. So that should be it, the routine checkup.
And I think the routine checkups, like you said, and the most important thing which you mentioned early on in the podcast was that make sure your diet is on point, make sure you're healthy. And I think the most important thing is also to be in the right mindset. That whatever your doctor is telling you, you're able to comprehend and not be defensive. Most patients are defensive that we have already done all this. You are telling us something that we cannot do it or something like that. So
it's very difficult to convince a set of population, but that is where I feel we as doctors need to have that extra patience. Put yourself in their shoes and think, after having that huge of a file, that many pricks, that much of blood being drawn from them, that many failures that they have faced, that is what I have learned. Be patient.
Right.
Give them the time. They want to understand it. Let's talk about it again. Let's understand where we have lost. What are the extra things that I can do for you?
Right.
So let's sit down and talk about it. It will take a little bit of a time. They will take a little time. I will take my time because I need to evaluate you more. So patience really matters, especially in our field and infertility. Patience from both the sides matter.
Yeah. I think it's so very important that both of them are sensitized and then a good family history. Thank you, ma'am. It's been wonderful. I think it's a huge world, especially if we have to go to immunology. We can keep talking for hours and hours, but I think it's a never ending thing. But I think this is a great start for people to at least know that these problems exist.
Lovely talking to you. I'm so glad you've brought up such topics which is still in the dark.
Yeah.
So I am sure a lot of women are going to benefit from this.
Yes, definitely, ma'am. Thank you so much.
Thank you so much.